Good evening, and welcome to NCODA's Student Educational Talks. Thank you for joining us for this month of February. I would now like to turn it over to Riley Moore for our opening remarks.
Yeah, thanks, Austin. So, for those of you who don't know me, my name is Riley. I'm a current P3 at the University of Iowa College of Pharmacy. I'm serving as the current president. We're going to start off with our PSO mission statement. Our focus is to offer an international community for healthcare students with passion in oncology and pharmaceutical industry. We provide education, leadership, mentorship, and opportunities in research and community outreach. We promote unique and dynamic experiences for students to collaborate with all oncology stakeholders. At this time, I'd like to welcome all the established NCODA professional student organization chapters: South University, University of Rhode Island, Midwestern University, North Texas University, Washington State University, Texas Tech University, Purdue University, Nova Southeastern University, Massachusetts College of Pharmacy and Health Sciences, University of Minnesota, University of Toledo, Albany College of Pharmacy and Health Sciences, University of Iowa, Lake Erie College of Osteopathic Medicine, Auburn University, University of Missouri Kansas City, Binghamton University, University of New Mexico, Belmont University, Wingate School of Pharmacy, University of Florida College of Pharmacy, University of Utah College of Pharmacy, Howard University College of Pharmacy, Temple University, Shenandoah University, Oregon State University, and University of Toronto. I would also like to welcome all the In Progress and NCODA professional student organization chapters as well. And I also want to thank you for continuing to help us expand. Next, I'd like to welcome any and all students listening in. NCODA will be providing student educational talks to all students, regardless of membership. And as you all know, NCODA is growing by leaps and bounds. Currently, we're at 3,100 plus members and 530 plus practices strong. Working together, we become stronger. Stay up to date on all NCODA student events and resources by following the NCODA Professional Student Organization Facebook and Instagram page at facebook.com/NCODA Professional Student Organizations, or you can go ahead and scan the QR code on the screen right now. Also, don't forget to follow NCODA's LinkedIn page for all national updates.
Thank you, Riley. I would now like to turn it over to our first presenter, Nelsie Zaninga.
Hi, thank you so much. So good evening, everyone. My name is Nelsie Zuniga. I am a P3 student at Nova Southeastern University's College of Pharmacy, and I'm very honored to be here tonight talking about tumor lysis syndrome. It'll be a brief overview. Next slide, please. So the objectives of my presentation will be to define tumor lysis syndrome, which I'll be referring to as TLS at times, and the different classifications. It'll also be to understand the pathophysiology of TLS and to identify the associated risk factors and symptoms, and also to provide a management and monitoring strategies. Next slide. So what is tumor lysis syndrome? TLS is the sudden release of cellular components into bloodstream due to lysis of malignant cells. When we initiate certain cytotoxic therapies, we run a risk of developing this condition. So this oncologic emergency is life-threatening, which is why it is imperative to identify patients who might be at risk. So TLS may lead to acute kidney injury, neurological complications, cardiac dysrhythmias, seizures, and even death. The figure to the right shows the cellular components that are released into circulation in the presence of TLS. So we have nucleic acids, we have potassium, and phosphorus. Shortly, we'll discuss the implications of these components accumulating into the circulation. So next slide, please. So there are two classifications for TLS according to the Cairo and Bishop system. We have laboratory and clinical. So to be defined as laboratory tumor lysis syndrome, 2 or more of the metabolic abnormalities to the right must be present either 3 days before or up to 7 days after initiating treatment. So the patient might present with hyperuricemia. So that will be a uric acid level greater than 8 milligrams per deciliters in adults. The patient might also present with hyperkalemia, which might be a potassium level greater than 6 in adults or greater than 6.5 in children. Also, the patient might present with hyperphosphatemia, which would be a phosphorus level greater than 4.5 in adults or greater than 6.5 in children. Also, hypocalcemia, which can be a corrected calcium less than 7 milligrams per deciliter, or an ionized calcium less than 4.5 milligrams per deciliter. So to be defined as the clinical TLS, the patient must meet the requirements for laboratory TLS that we just discussed, as well as present one of the following manifestations. So they can present with either an increased creatinine level, seizures, and cardiac dysrhythmias. And these manifestations are frequently caused by the initial metabolic abnormalities that we recently discussed that may be present in those patients as well. So next slide. All right, so now we're going to briefly discuss the pathophysiology of tumor lysis syndrome. As previously mentioned, TLS occurs when the cancer cells lyse upon treatment initiation, and in some instances, it may occur even prior to the treatment. So the components that are released, as you can see here, are the nucleic acids, the phosphate, the potassium, and also cytokines may be released. So a release of nucleic acids, as you can see from the figure, we're going to focus on the purines in particular because those are going to lead to the development of hypoxanthine, which converts into xanthine in order to create uric acid. So you can see here allopurinol and rasburicase. Allopurinol will block the conversion from hypoxanthine to xanthine, and that usually prevents more uric acid from forming, while rasburicase will directly target the uric acid. We'll touch base a little bit more in the management section, but if the patient is intolerant to allopurinol, they can also be recommended to start on febuxostat. So then we have phosphorus. As phosphorus is released, it can cause secondary hypocalcemia, which can lead to some of the complications that we discussed before, like the seizures and dysrhythmias. Then we have potassium, which an accumulation of this may lead to dysrhythmias as well, which may also be fatal in some circumstances. So as the malignant cells lyse, cytokines might also be released, which can cause hypotension and inflammation, and in some cases, it can cause multi-organ failure. So all of these cellular components that we're discussing right now, they're typically excreted renally, so the body's inability to excrete is a major factor in the accumulation of these products and the severity of the tumor lysis syndrome. And this tissue injury may occur in the kidneys, preventing that excretion. And like previously mentioned, it would exacerbate the TLS even further. So next slide, please. So moving on to the risk factors of TLS, it's very important to be able to identify these in order to monitor the patients more carefully and even potentially treat them to prevent TLS. So some of the patient-related risk factors include hypotension, oliguria, dehydration, acidic urine, pre-existing kidney disease, advanced age, and alcohol use. The cancer-related risk factors include rapidly proliferating cancer cells and large cancer mass, in particular, patients with Burkitt lymphoma, lymphoblastic lymphoma, B-cell acute lymphoblastic leukemia, and solid tumors are considered low risk, but there are some exceptions such as neuroblastomas, germ cell tumors, and small cell lung cancer. And even using some agents might also increase the risk of TLS in patients. So if a patient is using avalsidib, lenalidomide, venetoclax, cytarabine, cisplatin, etoposide, or paclitaxel, they might be at a higher risk of developing TLS as well. So next slide, please. So now we're gonna just move on to symptoms. Patients may present with either shortness of breath, cloudy urine, flank pain, muscle cramps, nausea, vomiting, lethargy, and irregular heartbeat. It is very important for us to be able to keep these symptoms in mind as we are evaluating patients and as we are monitoring them. That way we can assess who is at a higher risk of developing TLS. That way we can have more careful interventions for them. So next slide, please. All right, so now we're going to be focusing on management. It is imperative always to initiate hydration always, especially if the patient has one of these high-risk cancers that we previously discussed. So the recommended is the IV fluids 2,500 to 3,000 mLs per meter squared per day. And this should be initiated 2 to 3 days before treatment, and it should be continued on 2 to 3 days following the treatment. So then allopurinol will minimize the uric acid production. So it is recommended to initiate it 1 to 2 days before the treatment and continue it on 7 to 14 days following the treatment. If the patient is intolerant to allopurinol, as discussed in our pathophysiology section, then the febuxostat may be used. The recommended dose for allopurinol, it can be either given IV or orally. For the IV, it'll be the 200 through 400 milligrams per meter squared per day, which can either be given in a single daily dose or divided in 2 to 3 doses. It can also be given orally, which would be 300 milligrams per meter squared per day, or the 10 milligrams per kilograms per day in 3 divided doses. Then we have the rasburicase, which this one directly targets the accumulated uric acid in the patient already. So it is the agent of choice in patients with large tumor burden and excessive uric acid. And when considering the use of rasburicase, it is important to note that this agent is contraindicated in the G6PD deficiency. So you must assess that before starting it on patients. The recommended dose for rasburicase would be IV, and it'll be 0.05 through 0.2 milligrams per kilograms once daily for 1 to 7 days. And this dose is dependent on the uric acid levels of the patient, and it is also dependent on the patient's risk. So prophylaxis should be considered when the patients present with Burkitt lymphoma, lymphoblastic leukemia, or any of the high-risk cancers that we discussed previously. Next slide, please. All right, so monitoring is key in these patients. These patients are at risk for potentially fatal complications, so it's very important to be able to monitor their urine output, their electrolytes, the uric acid level, their creatinine, and also their EKGs for potential dysrhythmias. So high-risk patients should be monitored every 4 to 6 hours, while low-risk patients should be monitored daily. And next slide, please. So I want to conclude this brief overview by just emphasizing the importance of our roles as future and current pharmacists when managing patients at risk for TLS. So pharmacists have the ability to identify the contraindications to possible medication regimens, such as the contraindication that we discussed previously, the G6PD, in patients who we might want to treat with rasburicase. They also can assess treatment-related risk factors that require immediate attention, and they're able to develop personalized regimens to manage TLS within an interdisciplinary team. So being the medication experts, pharmacists have the ability to prevent these fatal complications. So it's very important that we're always included in the interdisciplinary team because we can make a major impact in the patient's progress who have these high-risk tumors and cancers. So thank you so much for your time. And the next slide will feature the references that I used for the presentation. And if anybody has any questions, I'll be more than gladly to answer them. Thank you.
So one question I had for you, I know some of the symptoms you mentioned are pretty generic. So when you're discussing this with a patient, how do you differentiate that between just how they might generally be feeling due to their cancer?
Hi, Dr. Starkey. Thank you for the question. Yes, so I think that we would definitely, if they have one of those high-risk cancers, for sure, I think we would try not to alarm them, but also have them recognize that, hey, if you're feeling this, we should monitor you closely because it might be, it might be a bigger complication to what you're already having. So it's definitely tricky because they are a bit vague, but it's something that the patient at least should be aware of, that if you're feeling this specifically or more than usual, then it's something that we should definitely keep in close considerations.
Hi, can you hear me?
Yes, I can.
Okay, I'm sorry. My question is actually about the pathophysiology of the disease state. I noticed that in your presentation, which was really good, by the way, thank you for doing it, that you said that the cell lysis can be treated a few days before treatment. And I don't really understand how cell lysis, like why the cell lysis is occurring if it's happening before treatment? Because I thought it was the treatment that was doing it.
Yeah, so that is a rare occasion. Usually it's after the treatment, but in some studies it has been shown that tumors and cancers with large mass may just this might spontaneously occur. So it's not a common occurrence, but which is why it's very important to just overall treat the patient with those fluids and the hydration to prevent any of that from happening. But before, it's a little bit more rare compared to the tumor lysis happening upon initiation, which is the common factor. But I wanted to include that because, I mean, it's a rare case, but it can be seen.
Good to know. Thank you.
You're welcome.
Yeah, hi. That was a good presentation. I just had a quick comment on rasburicase. So you kind of mentioned that it's used more for the more severe cases, so that's accurate. So like rasburicase is pretty expensive. It's around $2,000 for every 3 milligram dose. So typically patients with like a high tumor burden are getting 6 milligrams of rasburicase. So that's about $4,000. So it's really only used like in specific certain circumstances with malignancies with high tumor burden. So like kind of like you mentioned, like the leukemias or the Burkitt's lymphoma, not really used for the solid tumor. So it's also important for pharmacists to assess the necessity of rasburicase and if it's really needed. So it's really important to really optimize the allopurinol, the hydration, and the supportive care as well. So like treating the hyperkalemia, hyperphosphatemia as well. So it's really important to evaluate if rasburicase is really necessary. And a lot of institutes have their own specific policy about when rasburicase is necessary. And another thing that comes up a lot is when to check uric acids, because a lot of physicians and teams want to check uric acid like right away after rasburicase, but rasburicase actually works for 24 hours. So you'll see the uric acid drop for over 24 hours. So you really want to ensure the team to continually check uric acid at the 24-hour mark, because it will continually drop the uric acid after rasburicase. So a lot of teams will check a uric acid maybe 2 hours later and they won't see the drops that they want. They want to give another dose of rasburicase. So that's another role for the pharmacist to really implement their input and say the half-life is about 24 hours, so you'll continue to see those drops for 24 hours. But I thought that was just this comes up a lot in practice, so I thought that's important to bring up.
Great, yes, thank you so much for that. I'll definitely keep that in mind for the future. Thank you.
Hi, Nelsie. Great job.
Hi, thank you, Manny.
Very interesting topic.
Thank you.
I just wanted to say the same. Great job, Nelsie. This was a really good presentation.
Thank you very much, Arelis.
All right, thank you, Nelsie. I would now like to turn it over to our next presenter, Benjamin Bauer.
Thanks, Austin. Hi, my name's Ben Bauer. So a little bit of background on me. I went to pharmacy school at Chicago State University in Chicago. Ended up doing my PGY1 in Chicago as well at Rush University Medical Center. And I'm the current PGY2 Hem/Onc pharmacy resident at the University of Chicago. So today I'm going to be going over neutropenic fever. It's one of my favorite topics in like the supportive care series for Hem/Onc. So I'm really excited to give this lecture. And thanks, Austin. So next slide, please. So just some objectives for today. I won't go through all of them individually, but by the end of the slide set or the presentation, if you're able to answer all these objectives, you should be able to effectively treat patients with febrile neutropenia. Next. So the definition of febrile neutropenia or neutropenic fever is going to be the combination of, as you guessed, fever and neutropenia. So fever is going to be defined as a temperature above 38.3 degrees Celsius. So that's a one-time occurrence, or you can also have a fever that's greater than 38 degrees Celsius over a 1 hour period. And then the opposite side of that is going to be neutropenia. So neutropenia is going to be defined as an ANC below 500 or ANC that's expected to drop below 500 within the next 48 hours. So neutrophils are going to be important for fighting off infection. So if you have a low neutrophil count, you may be more predisposed to developing an infection. And this is definitely more common as with tumor lysis syndrome. This is going to be more common in patients with hematologic malignancies. So what I mean by hematologic malignancies is going to be cancers such as leukemia, multiple myeloma, and not really some of the solid tumors that you would normally associate, like breast, lung. It's not really associated with those disease states. Next. So looking at different etiologies of fever, the most common one that probably comes to mind is infection. You can also have mucositis, which is going to be kind of the sloughing and inflammation of the mucosal membranes. You can also have a tumor fever. So the tumor itself, depending on the tumor burden, can release inflammatory cytokines such as IL-6, interferon alpha, IL-2, which can cause a fever as well. You can have drug fever, so definitely important for the pharmacist to assess whether the patient has had allergies in the past or if this specific drug is associated with fever, and then blood transfusions as well. Next. So looking at risk factors for infection, so hematologic malignancies again, so specifically acute myeloid leukemia or AML. So AML is associated with disruption of granulocytes, which are important for the formation of neutrophils. So neutrophils, again, are important for fighting off infection. So patients with hematologic malignancies may have low neutrophil counts, either based on the disease itself, because the disease is so rampant and these cells are actively lysing, or it could be due to the chemotherapy. And then it could also be risk factors for infection could also be disruption of mucosal barriers. So specific chemotherapy regimens can disrupt your mucosal barrier, and this can expose different bacteria. So specifically strep viridans, streptococci, and Candida. So this becomes a problem when there's a disruption of specific bacteria within your mucosal barriers, because these can travel to different organs of your body, so specifically the heart. And this can cause endocarditis. And there are also other comorbidities and factors such as different medications, such as immunosuppression and COPD that can predispose patients for infection. Next. So once a patient presents with neutropenic fever, so they have a fever, low neutrophil counts, it's important to work up a specific infection. So it's important to right away get blood cultures to see if there's any bacteria growing in the blood, because this is highly associated with increased morbidity and mortality. So you can either get blood cultures from a central line or a peripheral line, or two cultures from different peripheral lines. So it's important to get two different cultures, because if there's only one culture with a specific bacteria, it may be a contaminant. And it's more likely if you have two different blood cultures from two different sites growing the same bacteria, that may be a better indication of a bacteremia. You can also get site-specific cultures. So if a patient is having increased diarrhea, you can get a screening for C. diff, because this may be the source of the infection. You can also get urine cultures and potential skin biopsies, which is less common. And then you can also do a diagnostic workup in terms of imaging, getting chest x-rays and different laboratory markers. Next. And then some of the most common pathogens that are associated with febrile neutropenia. So the more commonly isolated organisms are actually going to be gram-positive organisms at about 54%, such as coag-negative Staph aureus, Enterococcus, and Strep pneumoniae. While on the other side, gram-negative is less common at about 37%, with the most common bacteria being Klebsiella, Enterobacter, Pseudomonas, and Citrobacter. So although gram-negative is actually less common, this is what we're empirically treating. So in patients who present with a neutropenic fever, it's going to be the most important that we empirically cover and empirically treat for gram-negative bacteria. So the reason for this is the gram-negative bacteria are associated with the most increased morbidity and mortality. So it's extremely important that we cover for some of the most virulent gram-negative bugs. So that's going to be specifically Pseudomonas. So the backbone of our treatment for febrile neutropenia is going to be Pseudomonal coverage. Next. So depending on the patient's risk factors, so there are lots of different risk factors that we can calculate. So here is a tool that we can use, such as it's called the Multinational Association for Supportive Care and Cancer Risk Index Score, or the MAS score. So high risk is going to be a mass score below 21, while low risk is going to be a score above 21. And this is typically treated with outpatient therapy, and high risk patients are typically going to be treated with empiric antibiotics in the hospital. And the table on the right is just a scoring tool that's used to kind of assess each patient with a score. This isn't necessarily used in practice, but it can be a good tool for learners as well to kind of see what are some of the risk factors associated with developing febrile neutropenia. So it's kind of the same things we talked about in terms of hematologic malignancies and just overall burden of disease. Next. So like I mentioned, so for febrile neutropenia, we're going to be concerned for infection. So we're going to be starting antibiotics. So that's going to be the backbone of therapy. So here's a quick diagram of the mechanism of action of some of the main classes of antibiotics. So we're going to specifically focus on beta-lactams, which include the penicillins, cephalosporins, and carbapenems, and also vancomycin. So these inhibit cell wall synthesis. And then we're also going to focus on fluoroquinolones, which are going to inhibit nucleic acid synthesis. And one of the other big classes are going to be aminoglycoside, which inhibit protein synthesis, specifically the 3S ribosome. Next. So here is just a brief overview of some of the antibiotics that are used for febrile neutropenia. So I mentioned the main bug we want to cover is actually going to be Pseudomonas. So some of the main pseudomonal agents that I think of are going to be cefepime and piperacillin tazobactam, also known as Zosyn. So we actually, both of these actually cover Pseudomonas, but the difference between cefepime and piperacillin tazobactam is going to be mostly anaerobic coverage. So Zosyn or piperacillin tazobactam actually covers anaerobes, which are mostly associated with intra-abdominal infections. So it's an important point when you're thinking about treatment of specific infections. You want to be as narrow as possible because this helps reduce resistance rates to various bacteria. So if we're using the biggest guns possible, there's going to be increased resistance. So it's important to have the most narrow therapy that's treating the bug you want to treat. So that's why we actually use cefepime. And at my institution, a lot of our susceptibilities for Pseudomonas is most susceptible to cefepime as well. So it's even more narrow and it even works better. Then we have meropenem, which is going to be a carbapenem, and this is associated with ESBL or extended spectrum beta-lactamase bacteria. So this is a pretty resistant bacteria that we have to use big guns. So this is the only case when you should use meropenem is in patients who have an ESBL infection. Then we also have ciprofloxacin and levofloxacin, which are going to be fluoroquinolones. And these are mostly used for prophylaxis, which I'll talk about a little bit later. But from the standpoint of a pharmacist, in terms of monitoring parameters, you definitely want to be checking QTC with these agents. These are known QTC prolonging agents. So it's important to evaluate QTC when these patients are started on that. But again, these are mostly used for prophylaxis. So kind of the main point of this slide is that we are starting cefepime empirically on all patients. Well, I guess I shouldn't say that. It is institution specific, but for most institutions, cefepime is going to be the agent of choice for empirically treating febrile neutropenia. Next. So here's kind of breaking down what I just talked about. So patients who are candidates for oral regimens, some of the oral regimens include amoxicillin or clavulanate or Augmentin and ciprofloxacin. And some of the patients who are high risk, kind of like I talked about, the mainstay of treatment is going to be anti-pseudomonal beta-lactam, so cefepime. Next. So here's a quick trial breaking down patients who have low risk factors, and it wanted to determine if it was appropriate to treat patients with low risk factors with oral agents. So this essentially randomized patients who had low risk factors for febrile neutropenia to either oral regimens or IV regimens. So it actually showed that treatment failure occurred in 13% in the oral group and 32% in the IV group, and this was statistically significant. So this is kind of just justifying in patients who are low risk or have some of those low risk factors based on the mass score, oral regimens are actually appropriate. Next. So here is kind of an algorithm that is, here's an algorithm that is used for the treatment of these high risk patients. So the mainstay key of therapy is going to be don't delay therapy. So in a patient who immediately spikes a fever and is neutropenic with an ANC below 500, you want to start cefepime right away. And this is because a lot of, and mostly in a typical scenario, you would want to wait for a positive blood culture or some kind of indication of what we're treating. But actually in febrile neutropenia, we don't actually find an exact source. Actually, in only about 20 to 25% of cases are we actually going to have a positive blood culture. So we won't actually ever, most of the time, know what source we're treating. We're empirically treating this febrile neutropenia to prevent the infection. So we're starting pseudomonal coverage right away, so specifically cefepime. In some cases, we can start vancomycin, which I'll talk about next. Aminoglycosides are going to be used if patients are hemodynamically unstable. So if patients are having increased respiratory rate, hypotension, or altered mental status, this is a time when we could add on an additional aminoglycoside in addition to our cefepime. Antifungal regimen, or if you have multi-drug resistant bugs, you can add meropenem, kind of like what I talked about. And if there is some concern for anaerobic source, or if there's some indication that the infection is coming from an intra-abdominal site, you can also add on flagyl or metronidazole. But kind of the main concept is to always start cefepime in these patients. So next. So vancomycin. So vancomycin is going to be a drug that targets cell wall synthesis. And it's associated with a lot of different adverse effects. So one of the main adverse effects is going to be nephrotoxicity. So it's extremely nephrotoxic, and that's why it's important that we monitor trough levels of vancomycin in all patients who are on it. So for those reasons, we're not always starting vancomycin on all patients. We need specific indications. So vancomycin is very good for gram-positive coverage, specifically MRSA or MRSA, also known as methicillin-resistant Staph aureus. So this is going to be used for multi-drug resistant bacteria, so specifically patients who have MRSA. And some of the main indications are going to be septic shock, if the blood cultures grow gram-positive bacteria, pneumonia or PNA, cellulitis, and mucositis. So if patients have some indication that they need gram-positive coverage in addition to their gram-negative coverage, then we'll start vancomycin. Next. So here's a trial kind of looking at the different antibiotics that we use. So this was a meta-analysis that wanted to compare the effectiveness of beta-lactam monotherapy versus the addition of beta-lactam and aminoglycoside together. So the primary outcome of this trial was to look at death at the end of 30 days post neutropenic fever. So again, this looked at beta-lactam monotherapy versus beta-lactam in addition to aminoglycoside. And it actually showed that patients who were treated with beta-lactam, who were just treated with beta-lactam monotherapy, had better overall survival rates. Next. So duration of therapy can kind of be tricky. So it kind of depends on what we're treating. So if we know the patient has a SSTI or a soft skin and tissue infection, the duration could be 7 to 14 days. Bacteremia can again be anywhere from 7 to 14 days, depending on if it's a gram-negative or gram-positive bugs. For pneumonia, again, 7 to 14 days, but this gets tricky because we don't always have a source, like I mentioned. So it's really important to always evaluate, mostly on a 24 to 48-hour basis, to see if antibiotics are still necessary. Next. So that's where the modification of therapy comes in. So this kind of just reiterates what I just said. So you really want to assess if there is a need for antibiotics. So a lot of the times we're starting patients on cefepime right away at the development of this fever and neutropenia. But it's also important to evaluate, are we missing coverage? So on a 24 to 48-hour basis, if the patient is continually to spike fevers, then we should add on additional coverage. So are we missing gram-positive coverage? Are we missing fungal coverage? What are we kind of missing? And we can reevaluate our antibiotic regimen to see if changes are necessary. So next. So if patients are still spiking fevers, we started them on cefepime, we've started them on vancomycin, they have gram-positive, they have gram-negative coverage. The question is, what are we missing? So if patients are still spiking fevers 4 days after starting therapy, then we start to think of antifungal coverage. So is there some fungal source that we aren't treating. So it's important to cover for antifungal sources. So next. So I'm going to talk about some specific antifungals, so kind of going into the mechanism of action of different antifungals. So there's a class of antifungals called azoles. So the azoles inhibit the transition of lanosterol to ergosterol. And ergosterol is important for the synthesis and formation of fungal cell membranes. We also have echinocandins, which I kind of think of as the beta lactams of the fungal class. So they inhibit or fungal wall synthesis. And those are kind of the two main classes I wanted to talk about. So next. So here is a spectrum of activity of the different antifungal agents that are used. So if you haven't seen this yet in school, I'm sure you will, and you'll get familiar with it. I know this can be overwhelming, but I'm just going to point out some of the main things you should know coming out of this table. So at the top, we have fluconazole, itraconazole, voriconazole, and posaconazole, and isavuconazole. So these are all, as you guessed it, going to be azole antifungals. So there are slight differences between these. So starting with fluconazole, so this is pretty good for Candida coverage. So Candida is going to be a fungus that is mostly covered by fluconazole, and some of the differences between itraconazole and voriconazole are going to be aspergillus coverage. So itra, vori, and posaconazole and isavuconazole are all going to cover aspergillus. So that's going to be one of the main differences between a fluconazole and some of these other drugs. And then mycofungin, which is going to be echinocandin, is also good for Candida and aspergillus coverage. So aspergillus is associated with high morbidity and mortality, and it's going to be a mold that's important for coverage for various hematologic malignancies. So it's important to consider what fungus we want to cover. Do we want to cover Candida or do we want to cover aspergillus? This will help guide our formation of what antifungal we should pick in terms of antifungal coverage. Next. So again, here are some of the main antifungals we use. I kind of already talked about them. So looking at the azoles, again, this is a big intervention for pharmacists. One of the big monitoring parameters for pharmacists are going to be that azoles can increase liver functional enzymes because they are metabolized by CYP3A4. So if you guys may or may not have heard, there's lots of drugs that can interact with CYP3A4. So it's important to monitor your patient's medication list to see if there are any medications that interact with the antifungal regimen and if there are any modifications that need to be made. So similar to our fluoroquinolones, antifungals can actually prolong the QTC as well. So it's important to check that. So there are three big things I always think about with the azoles that are definitely NAPLEX-based questions. That's going to be increased LFTs, QTC prolongation, and drug-drug interactions. Amphotericin isn't necessarily as used as much for upfront therapy. This can typically be used depending on the resistance rates or kind of the patient history, because this is associated with nephrotoxicity, so very nephrotoxic, and electrolyte abnormalities. Next. And there are therapeutic drug monitoring of azoles, so we can get levels to ensure that we are giving the patient the right amount of antifungal coverage. I won't get into this specifically, but that's just here more for your information that we can draw posaconazole, itraconazole, and voriconazole levels and adjust accordingly to see if we need to change our antifungal regimen. Next. Here is just a trial kind of looking at empirical coverage using voriconazole and liposomal amphotericin B. So it just essentially shows that the success rates are pretty similar and there's no difference in mortality, but liposomal amphotericin B was associated with more renal toxicity. So in terms of covering for aspergillus, we typically upfront use voriconazole just based on a toxicity standpoint. Next. And de-escalation. So I kind of alluded to this previously in terms of resistance rates. So we need to constantly reevaluate if antibiotics or antifungal coverage is necessary, and we need to de-escalate if necessary. So again, we're doing this on an every 48 to 72 hour basis. So if a patient has been afebrile and they've been on antibiotics for 72 hours, it's an important intervention for the pharmacist to say, hey, can we get off these antibiotics now and reevaluate? That's pending the patient has been afebrile for over 72 hours and there's no positive blood cultures or any indications that the patient has an infection. And this is typically done in patients, again, who are neutropenic. So next. Here is just a trial looking at the importance of de-escalation. So this looked at patients who were over 18 years or old who had transplant or allogeneic stem cell transplants and developed neutropenic fever. So this essentially broke randomized patients into two groups. So early de-escalation within 72 hours and late de-escalation. So patients in the early de-escalation group were stopped on their antibiotics after 72 hours if they had no fever, and late escalation was about 1 week on antibiotics. And it actually showed that there were higher rates of reoccurrence in the late de-escalation arms, and there was actually higher mortality rates in the de-escalation arm and higher resistance rates as well. So this is a very important role of the pharmacist and what they can provide to the team in terms of de-escalating antibiotics and being a good antibiotic steward. Next. Then there comes the concept of granulocyte colony stimulating factors, or GCSF. So GCSF, as you can see in the diagram from the bottom right-hand corner, binds to GCSFR, or the GCSF receptor. So what GCSF does can actually promote cell differentiation and reduce apoptosis. So this essentially can increase your neutrophil counts. So it's kind of an artificial way to help increase your neutrophil counts, which can be important in patients, obviously, with a neutropenic fever. So this can be a tool that can be helpful in specific malignancies or specific circumstances. So next. So this is just kind of breaking down different risk factors in which patients should get GCSF. So you're only giving GCSF in high-risk patients and patients who may benefit. So in patients who have a very prolonged neutropenia, if it's sometime from a week to 2 weeks, older patients, and patients with a history of pneumonia. And you can also take into account, which is a little more advanced, where they are in their overall treatment of malignancy. So are they going to be cured with their malignancy, or are they more just a palliative or symptomatic relief of their overall malignancy? Next. So granulocyte colony stimulating factors, so the NCCN guidelines recommend it in high-risk patients, which is a category 1 recommendations, but for more of those low risk or intermediate risk patients, it isn't necessarily used all the time. So next. So there are some risks and benefits to just giving GCSF. So you might think, oh, this GCSF, it can increase neutrophil counts. Our patient is neutropenic. Why don't we just give it? So there are some risks. So it is associated with allergic reaction, and it also is associated with bone pain. So the mechanism of bone pain is actually GCSF promotes your neutrophils to come out of the bone marrow and into the periphery. So this mobilization or this transition of neutrophils out of the bone marrow is actually histamine release. So the patients may actually get some bone and joint pain. So this can be treated with histamine antagonists such as Claritin and can be helpful in reducing that bone pain. So you're not necessarily using some of those high intensity opioids, but rather you can just use a histamine antagonist to help with this. But there is benefits, like we already talked about. It reduces your overall incidence and duration of febrile neutropenia. Next. Then from a prophylactic standpoint, so a lot of these patients who are neutropenic for a prolonged period of time may not never spike a fever, but we still want to use prophylactic or preventative antibiotics, antifungals, and antivirals. So this is because patients are still neutropenic, so they are at a high risk of infection, so you want to use preventative antibiotics. So kind of the main concept of preventative antibiotics are going to be antibacterial. So we're mostly going to use our fluoroquinolone levofloxacin because this is another agent that can cover Pseudomonas. For antifungals, we can use a fluconazole or posaconazole, and antiviral coverage, we're going to be using an acyclovir. Next. So this is just kind of essentially redefining what I just stated, but one of the differences is going to be in terms of our antifungal coverage. So you can see in the middle our intermediate risk groups, which are going to be our lymphomas, our multiple myelomas. So intermediate risk groups, these patients mostly get fluconazole for their antifungal coverage. But for the high risk groups, such as our acute leukemias or patients who undergo stem cell transplants, typically get actually posaconazole. So because a lot of these high risk groups are going to be more prone to developing aspergillus. So remember, the difference between mostly or essentially between fluconazole and posaconazole is going to be aspergillus coverage. So posaconazole is a little bit wider range in terms of its coverage. So for those higher risk patients, we're treating them preventatively with posaconazole. Next. And we can skip past these. These are just some more studies kind of breaking down the differences between antifungal coverage. Here are my references, and I know that was a lot of information. I'd be happy to take any questions at the moment. And if there are no specific questions, I'll put my email in the chat. Feel free to shoot me an email, any questions, or I'm happy to take questions now. Any questions about residency or anything in general, I'd be happy to answer any question.
I had a question, actually. Sorry about that. It's a quick question, hopefully, regarding the first trial that or the first study that you referenced. You said that in parenteral treatment was less effective percentage-wise, or had a higher rate of failure than oral. Was there information about why that was in the study, or?
Well, that was mostly for, if you go up to that trial again, potentially, I guess we don't need it, but that was again more for low risk patients. So it was treatment failure, I guess, is kind of it kind of depends on the definition of treatment failure. So going back to the trial, we can see that treatment failure, I guess, was associated with recurrent infections. So this was mostly just pointing out the fact that in patients who have low risk factors, so who may not necessarily need IV infection, we can use orals, because if you think about it, in patients who are low risk and don't necessarily need IV, that would be optimal, because if you think about patients in the hospital, they are actually more prone to develop infections. So that would be what I'm guessing. So, hospitals are filled with multi-drug resistant bugs. So MRSA, Pseudomonas. So in patients who can use the oral agents, they should. But I would point out that this isn't necessarily done in practice, and we don't necessarily see this all the time in practice. Mostly in patients who have febrile neutropenia are being directly admitted to the hospital and are getting IV antibiotics. But I would surmise that's probably what they meant, because it is a little safer in terms of patients to get antibiotics outpatient. They probably should if they could.
Thank you.
All right, thank you, Ben, for your presentation tonight. I would now like to turn it over to our next presenter, Jennifer Ratliff.
Hi, everybody. Thank you so much for having me. My name is Jen Ratliff, and I work with Genentech in our breast cancer division. So I support our breast cancer portfolio, which includes Tecentriq for metastatic triple negative breast cancer. So I've been asked by Austin to share some clinical information with you all regarding that. So I'm actually going to share my screen so I can pull up a clinical brochure. I'll probably stop my video here for a second. Okay. Can anybody confirm for me that you can see my screen?
We've got a blank white screen.
How about now?
We do see your mouse.
Oh, really? Huh. This is interesting. Okay. Let me attempt that again. How about now?
Yes, we can.
Oh, fantastic. Sorry about that. Okay. Okay, so Tecentriq is actually the first cancer immunotherapy that has been approved in breast cancer. So this was very exciting because historically there were very few options for patients with triple negative breast cancer. Really, we were looking at sequential chemotherapy. About a couple years ago, Tecentriq got the first FDA approval in the metastatic triple negative breast cancer setting. So this is a NCCN, actually category 1 preferred product now. It used to be category 2A, and recently it was just changed over to category 1. But down on the bottom, you can see what the indication is listed as. So Tecentriq in combination with paclitaxel protein bound is indicated for the treatment of adult patients with unresectable, locally advanced, or metastatic triple negative breast cancer whose tumors express PD-L1, which is defined as PD-L1 stained tumor infiltrating immune cells of any intensity covering greater than 1% of the tumor area, as determined by an FDA-approved test. So Impassion 130 was the trial that gave Tecentriq the indication. So this was a multi-center international double-blind randomized trial in patients who had not received prior chemotherapy for metastatic TNBC. So 902 patients with unresectable, locally advanced, or metastatic TNBC were randomized 1-to-1 to get either Tecentriq and nab-pac. I'm sorry, I'm just getting, can you not see the second page?
We cannot.
You cannot. Huh. I'm not sure what's going on here. All right. Can you see it now?
Yes.
I think I might just stay on this format. Hopefully you can see it okay. So patients were randomized to get either Tecentriq and nab-pac or placebo and nab-pac, and they were treated until radiographic disease progression or unacceptable toxicity. So the co-primary endpoints were progression-free survival in the intent to treat and PD-L1 positive populations, as well as overall survival in the ITT and PD-L1 positive populations. The secondary efficacy endpoints were objective response rate and duration of response in the ITT and PD-L1 positive populations. Stratification factors included PD-L1 expression status, liver mets, and prior taxane treatment. Down on the bottom is a kind of a red call-out box. And this is important because not all patients in this study were PD-L1 positive. Only 41% of those patients were. And the PFS results in this patient population that were PD-L1 positive is what led to the accelerated approval of Tecentriq and nab-pac in PD-L1 positive metastatic triple negative breast cancer. So the baseline characteristics were well balanced between the treatment arms. This graph is looking at PD-L1 positive population baseline characteristics, and they were generally representative of the broader study population. Just want to make sure, have we all moved on to slide 3? Okay, we have.
Yes.
All right, fantastic. So here on the left, we're looking at progression-free survival. So Tecentriq significantly improved PFS with nab-pac. So there was a 4.8-month median PFS for patients taking placebo and nab-pac versus a 7.4-month median PFS for patients on Tecentriq and nab-pac, which gave a hazard ratio of 0.6 for a 40% reduction in the risk of disease progression or death. For the interim overall survival analysis, down on the bottom, there's a couple call-outs. So OS in the PD-L1 positive population was a co-primary endpoint in the Impassion 130 study, but it was dependent upon OS results in the ITT population first. So therefore, overall survival in the PD-L1 positive population was not formally tested due to the statistical hierarchy plan. Therefore, the results here for OS should be considered descriptive, therefore exploratory. But what we saw for the PD-L1 positive population for overall survival benefit was 25 months for patients taking Tecentriq and nab-pac compared to 18 months in the placebo and nab-pac arm with a hazard ratio of 0.71. On the right-hand side is looking at the secondary endpoint of objective response rate. So more than half of patients responded to Tecentriq and nab-pac. So 53% responded and 9% of those had complete response versus 33% of patients on placebo and nab-pac responded with less than 1% as a complete response. I will call out on the bottom right-hand side some of the important safety information in terms of immune-mediated hepatitis, as well as immune-mediated colitis. And finally, on the bottom, immune-mediated endocrinopathies. So actually at the end of this brochure, I can pull up another brochure that's more specific to some of the adverse reactions that we do see with Tecentriq. So we can go through that in a little more detail. But this is looking at the adverse reactions based off the study for Tecentriq and nab-pac. So there were no new safety signals seen, and these side effects are consistent with the known safety profiles of both Tecentriq and nab-pac. So most adverse reactions were grade 1 or 2 with Tecentriq and nab-pac. So this graph shows adverse reactions with an incidence greater than 10%. And on the left side in the purple is your Tecentriq and nab-pac arms, which is broken down into all grades versus grades 3, 4. And on the right-hand side in the gray is your placebo and nab-pac for all grades and grades 3, 4. So for grades 3, 4, peripheral neuropathies that are greater than 1% for Tecentriq and nab-pac, as well as fatigue, nausea and diarrhea, back pain, and upper respiratory tract infection. Probably the most substantial difference in this graph would be the hypothyroidism at 14% compared to 3.4%. I won't go through all of the information on the right-hand side, but I will call out some of the discontinuation rates. So adverse reactions that led to discontinuation of Tecentriq or placebo was 6% and 1% respectively. Adverse reactions leading to interruption of Tecentriq occurred in 31% of patients, and the most common were neutropenia, neutrophil count decrease, hyperthyroidism, and pyrexia. Right here, we're going to look at the dosing schedule, which is very nice because it actually allows patients an infusion-free week between their cycles. So the dosing cycles is based off of a 28-day dosing cycle, and it continues until, of course, disease progression or unacceptable toxicity. So Tecentriq is given as an 840 milligram vial with nab-pac 100 milligrams per meter square on week 1. On week 2, patients just get nab-pac. Week 3, they get Tecentriq and nab-pac, and then week 4 is their infusion-free week. So for the 28-day cycle, Tecentriq is administered on days 1 and 15, and nab-pac is administered on day 1, 8, and 15. Tecentriq should be administered first, followed by nab-pac, and the administration of Tecentriq for the first infusion should be 60 minutes, and if this is tolerated well, then all subsequent infusions may be delivered over 30 minutes. It should never be administered as an IV push or bolus, not to be co-administered with other drugs through the same IV line. And Tecentriq and nab-pac may be discontinued for toxicity independent of each other. On the right-hand side here is a dose modification chart for various adverse reactions. And I have something else that I'll show you that's very similar to this. But there are, potential immune-mediated adverse reactions. And so on the left-hand side is the potential adverse reaction. In the center, looking at the severity of the adverse reaction, anywhere from grades 1 through 4 here, and what the dose modification would look like. I'm going to pull up again, like I mentioned, something that's a little more specific to that. But while I have this up, I can just share with you that Genentech does offer a variety of programs for patients in terms of helping them afford their medications through our Access Solutions program, as well as our copay program. So whether patients are not insured, underinsured, or even if they have a great commercial insurance plan, they can get some sort of support, as well as for those commercial patients, they can get $5 based on the copay card for a valid prescription. So I'm going to pull up right here. This is another resource, which is our dosing and adverse reaction management guide, which is really nice because in various sections, it talks about the preparation, administration, and storing of Tecentriq, also monitoring patients for signs and symptoms of these select immune-mediated adverse reactions, managing those adverse reactions with step-by-step instructions, and following up on management steps in terms of when to withhold, resume, and discontinue treatment with Tecentriq. So I will just kind of give you a little sample of what this looks like. So here we're looking at dosing and administration chart like we just reviewed. On the right-hand side discusses preparation of Tecentriq in terms of inspection, withdrawal, mixing, and discarding. On the bottom here is the storage of Tecentriq. So it does not contain a preservative, so it should be administered immediately once prepared. But if it is not, then it can be stored at room temperature for no more than 6 hours from the time of preparation, or it can be refrigerated for no more than 24 hours from the time of preparation. Of course, do not freeze or shake, and it's supplied in a 14 milliliter single dose vial for the metastatic triple-negative breast cancer indication. This chart right here on the left-hand side just looks at Tecentriq adverse reactions for patients receiving Tecentriq monotherapy. So this is 2,616 patients. On the right-hand side, it looks at the median time to onset for some of these adverse reactions. And you can see, for pneumonitis, for example, 3.6 months, but there's a very wide range in terms of onset. So 3 days to 20.5 months. So it can definitely range. On the bottom, your most common adverse reactions greater than 20% for Tecentriq with nab-pack: alopecia, peripheral neuropathies, fatigue, nausea, diarrhea, anemia, constipation, cough, headache, neutropenia, vomiting, and decreased appetite. This is looking at an example of some of these charts for monitoring these adverse reactions. So it shows, for example, immune-mediated pneumonitis, monitoring the patients for signs and symptoms, evaluating the patient's suspected pneumonitis with radiographic imaging, how to counsel the patients to inform their healthcare provider if they experience any of the following, for example. And then in terms of grading the immune-mediated pneumonitis and what the plan is, whether you're going to hold Tecentriq, if you're going to permanently discontinue it. So it goes through for immune-mediated hepatitis, colitis, endocrinopathies, other immune-mediated adverse reactions, infections, infusion-related reactions, and just some other additional dosing modifications. This is kind of the same information here. I can share with you that there's embryo-fetal toxicity for patients taking Tecentriq. So females should use effective contraception for at least 5 months after their last dose. And at this point, I'm happy to take any questions if there are any. And I can also forward this information as well as the package insert over to Dr. Starkey, who can forward it on to everybody else if necessary.
Yeah, Jen, I just had a question regarding the second dose. So I know the first dose has to be ran over that full hour, and if they are able to tolerate it, then you can go into the 30-minute subsequent infusions. How often do you have a patient not able to tolerate it after the first dose?
That's a fantastic question that I actually don't have the answer to, but I can get the answer to you from one of our medical science liaisons.
Okay, I just didn't know if it was a common thing. I would assume not with it based on that being the recommendation. I was just curious if there was any information on it.
Yes, no, and since I'm not on the main screen, I don't know who asked the question, so, but I'm happy to get the answer to you.
And then another question is, since we have a bunch of pharmacy students on the line here, what would be one takeaway that you would want to make sure that they know about Tecentriq if they're going to go off and start helping patients?
I think probably just maybe the awareness of these immune-mediated adverse reactions and the potential for them when you're using cancer immunotherapies. But also, the ease of dosing, I think, is very important too. There's not, it's pretty straightforward in terms of the 840 milligram vial. They're only getting the Tecentriq every other week, and then they've got their infusion-free week as well.
And then could you just elaborate a little more on what a category 1 would mean to a patient?
A category, in terms of the NCCN recommendations?
Correct.
So it's, yeah, so I guess, I actually don't have the chart in front of me in terms of it's the highest recommendation, I guess I could say, that the National Comprehensive Cancer Network gives to a product and its use in that specific patient type for that specific indication. So it's got the highest level of evidence, and it's a uniform consensus amongst the thought leaders in terms of the use of this product for these patients.
Okay, so as far as a category 1 recommendation, it is the
Yeah.
highest recommended it can be.
Correct.
All right, well, I don't see any more questions.
Okay, I can put this last slide up for you to close out if you'd like.
Yeah, we definitely thank you for your time, and we're definitely thankful for Genentech to be able to bring this drug to market as well. Definitely shown an impact on patients.
Thank you so much for having me.
All right, and as for everybody else on the call, I want to thank you for joining us in for this month's Student Educational Talks. And I did want to let you know, so you can put it on your calendar tonight, that our next Student Educational Talks will take place March 31st of this year. So the last Wednesday in March, again at 8 p.m. Eastern. So thank you all for joining us this evening, and thank you to our presenters for your time.